that we can have the Q&A, and that'll be an unrecorded portion of the presentation. So without further ado, I will introduce our speaker today. So Dr. Erene Stergiopoulos is a fifth-year resident in psychiatry and a first-year PhD student in health professions education research at the University of Toronto, where she is a research fellow of the Wilson Center. She holds a BSc in psychology research and an MA in history and philosophy of science from the University of Toronto. Can tell she's an underachiever. And under the supervision of Dr. Tina Martimianakis, her doctoral work uses critical qualitative methods to study the experiences of medical students with disabilities. And using a sociocultural lens, she's interested in processes of professional identity formation, as well as systemic and self-regulation of doctors and learners with disabilities, from training to licensure. And today she's going to talk about that end of the spectrum of her research, which is about licensure. So I'll turn it over to you, Erene.
Thank you so much, Neera. I'm very excited to be here today. Thank you for having me at the DREAM Research Rounds. So I'm going to be talking about licensure today, specifically physicians with disabilities, and the work that I and my supervisors have done in Canada specifically, but we're going to talk a little bit about the US context as well, and can also get a bit into the UK context if we have time, because all of these, there's really no one way that licensure is carried out in a jurisdiction. It's kind of the Wild West. So we're going to talk about that and what the implications are for physicians with disabilities. So first of all, I have no conflicts to disclose, but I want to talk about the fact that this whole presentation is about disclosure. So really, we're interested today in what it means to disclose a disability, specifically at the regulatory point of licensure for physicians with disabilities. So we're going to talk a lot about disclosure. So this is a question that I get asked a lot. I hear it a lot among my colleagues. I not infrequently will get an email or sort of a tap on the shoulder from another trainee, for example, like a final year medical student who has a disability, has talked to me about it because they know that I do this work, and will say, hey, I'm applying for my first medical license. I'm graduating. I'm, applying for a resident license. I have this disability. I don't know whether to disclose or not because I don't know if it's going to affect my medical license. I don't know what the process is. I don't know if it's going to have to get reviewed. I don't know if they're going to have to go through all my medical records. Can you provide some guidance? And the honest answer is, I don't have any good answers to this. And we'll see why today that is the case, at least in the jurisdiction that I practice in. But in a lot of jurisdictions, I think that a lot of transparency and clarity would be really helpful for people to make those decisions. And there's a lot of stress that goes into those decisions of disclosure. So we're going to get into kind of what are the unintended effects of the policies that exist right now. So when people when I, for example, have applied for my own license, you might see questions like this. So this is the licensing questions related to disability and medical conditions in Ontario, which is where I'm currently a resident. So the main two questions are, this is quite typical, both in the US and Canada. So the first one is, do you currently have any medical condition that affects or could affect your ability to practice medicine? And that's the second question. And sorry, there's usually a yes or no. There's not really a text answer. It's a yes or no that you have to drop down from the menu. And then the second question is, have you ever had any medical condition that has affected or could affect your ability to practice medicine? So we have the current, and then we have the historical question. And then we have the quasi fine print, which is, okay, well, if you say yes to any of these questions, you have to arrange for your treating physician to send directly to the college, which is our licensing board, a current report on your medical condition, setting out your diagnosis, course of treatment, present health, and prognosis. That's a lot of information. It's not very clear from this, snapshot, and from filling out this licensing application, it's not super clear, who is going to read this information, who will have access to it, who is it going to be, the hiring hospitals? Is it going to be the university? Who will be privy to all this data? that is suddenly personal health information. I'm seeing some questions, and so I'm going to keep these in mind as we go through, because these questions do exist in the US as well. It's improving, but we're going to get to that. So the question from one of the participants is, both questions would be impermissible under the ADA according to the US Department of Justice. So Canada's equivalent law, we have a few different ones. They're mostly provincial. In Ontario, we have the Ontarians with Disabilities Act. Canada-wise, I forget what it's called, but we also have a federal law, but it would be mostly provincial law that would regulate this. But again, licensing bodies somehow often do not follow what we would typically imagine to be the legal legal requirements. So if anyone is interested, I did publish on this with my two supervisors. Those are two co-senior authors, Dr. Martimianakis and Dr. Zaheer, on this very question. And so we published this in the Canadian Medical Association Journal just in May of this year, if folks are interested in the publication and seeing some of that work. But really, this work stemmed from much more of a qualitative interest in the experiences of people with disabilities in medicine. So this is sort of where I got started in this field, which was really doing critical discourse analysis and qualitative work on these experiences. How do medical students form their identities when they've experienced the system from a very different angle of having a disability, negotiating their care, negotiating their position as a student, potentially as a patient, and as someone who's now providing services to people in the system. And so that kind of evolved that research to understand, okay, well, when people are finishing medical school and they're graduating and they're getting into licensing, what's going on? What are the systems in place? So that's sort of how we landed here today. So just a little bit of a background on physician licensure in Canada. So some of the terminology, so medical regulatory authorities, or as they're called in Canada, colleges, are the provincial license granting bodies responsible for monitoring fitness to practice among MDs. And so really we're talking about licensing boards. We do know that licensing applications have been shown to pose barriers to help seeking and disclosure among physicians with medical conditions who fear the consequences of disclosure for their license. And we're going to talk about that reference at length. That's from Derby et al. From 2017. And so as a result of these findings that there are actually barriers to disclosure based on the licensing questions, like the ones that I showed before. So, have you ever had a medical condition? Do you have a medical condition that may impact your ability to practice medicine? There have been both Canadian, American bodies that have created consensus guidelines or guidance and best practices for actually asking those questions. How do we word those questions in a way that is not going to impede disclosure or discourage it in any way? There was no, up to the point where we were doing this work, there was no data on whether Canada was actually following that guidance at all. There was data from the US, which we're going to talk about. So some of that guidance is the following three principles. They're not too difficult to follow. And I've put the references down here. You can see there's both large Canadian and American bodies that have made these suggestions. Not all of them have made each one of the recommendations, but I have a little table in the CMAJ paper that sort of shows who has made what recommendation. But the really key statement that almost everyone across the board has suggested is to focus on current functional impairment, not the presence of a diagnosis or a treatment-seeking episode. So there has to be impairment and not just the presence of an illness or condition or disability. The question should not ask about past impairment, and they should not distinguish between mental and physical health. So this is the study that I mentioned by Derby and her colleagues. So this was done back in 2017 on the medical licensure questions across the US and effects on seeking care among physicians with mental health conditions. So they looked at 51 state medical licensing applications, and they sort of coded them and they divided them into two separate groups. The first was consistent. So these were ones that were consistent with the existing guidance, which was don't ask about mental health conditions, or the questions are limited to current functional impairment. So an example of what that question looks like is, do you currently have a medical condition which in any way impairs or limits your ability to practice medicine with reasonable skill and safety? The other category was inconsistent, which asks any historical questions about any kind of mental health history, regardless of functional impairment. So for example, have you ever had a condition related to your mental health that is impaired or could impair your ability to practice medicine? And these are lifted directly from the applications. This is direct wording. What they found was that 33, like one third of applications across the US were consistent with the guidance, and the other two thirds were inconsistent. So they then did a survey looking at care-seeking attitudes among US physicians. So they sent them to physicians all across the US. They got almost 6,000 responses. And what they found was that there were those who were reluctant. They sort of asked about care-seeking attitudes, and then there were those who were reluctant to seek care for a mental health condition due to repercussions on their medical license. And then there were those who were not reluctant. And what they found was that about 40% were reluctant to seek care. And those who came from states that had the inconsistent medical licensing applications were more likely to be reluctant to seek help. It wasn't a huge odds ratio, but it was significant. And so I do want to point out, though, that we are looking specifically in this paper at mental health only, which I think, doesn't capture all of disability. It does capture the most prevalent disabilities if we were to collapse ADHD into mental health. But again, this is now parsing and trying to carve, disability at joints that may not actually fit what people experience in their day-to-day lives and practice. So I want to move on to talking about the best practices. So thinking about these best practices again, it's not a large ask to have the licensing applications actually meet these standards or meet these practices. And what we found is that since these have come out in 2018 largely, the United States has actually improved quite a bit in terms of their questions. So going from, we remember that only 33% were consistent. It is now at, I think it's 77% are consistent with these recommendations. So there has been quite a bit of shift and change in the US. So I want to talk about the methods that we used to study the Canadian licensing procedures and policies. So we collected medical licensing applications from all 13 MRAs, or medical regulatory authorities, in Canada. We also looked at the policies as well for each of the MRAs. And then we coded them as aligned, so only asking about current functional impairment, not asking about past history or specific psychiatric diagnosis as separate from medical or physical diagnosis. And then, there we go, sorry. And then not aligned if they asked about historical impairment or treatment seeking, specific diagnoses in the absence of impairment. So, and then we applied critical policy analysis. We used specifically Carol Baki's approach, which is really about how is the problem represented? Like, what is the problem represented to be in terms of physician licensure for physicians with disabilities? And so we looked at the language, the framing, the implicit and explicit definitions of physicians' health and fitness to practice within licensing applications. So let's talk about our results. I first want readers, like people who are here today or who might be listening to this later on to the recording or watching the recording, to just sort of keep in mind, what do they think the percentage of Canadian colleges or licensing authorities, what percentage are actually aligned with the best practice guidance? Is it 23? Is it 33? Is it 64? Is it 91? If folks do want to venture a guess in the chat, that they're very welcome to. Otherwise, I'm also very happy. So, okay, so I see a B, so 33%. We can definitely keep that in mind as we go through the results. And it sort of helps us to kind of do a litmus test of our assumptions. And then an A, oh, wow, okay, even worse. Okay, I'm gonna move on. So it is actually A, it's 23% in our results. 23% of Canadian licensure applications were aligned with best practice guidance. So actually worse than the US was in 2017. Not to compare, not to play favorites, or not to make any kind of comparison, other than to say there's lots of work to do. And there's, it's very encouraging to see that the US has improved over the last 5 years or 6 years. So hopefully we can do the same in Canada. So here's a pretty map, but this is really to display kind of geographically what our results looked like. So 10 out of the 13 medical regulatory authorities were not aligned with best practices. So that's 3 provinces that were aligned. And then the stars that you see on the map, the pink stars, those are the ones that actually ask specifically about mental health and addictions. And so those were the provinces or jurisdictions where you would essentially have to disclose whether you'd had a mental health or addictions issue. So we're going to go through some kind of, let's like make this alive, right? Because it's one thing to have a map and to think, okay, abstractly, if I practice here, this is what I would have to ask on a licensing application. But I think this really, especially what we saw during COVID, was that movement between provinces or between jurisdictions was incredibly important. And it was helpful for population health to be able to actually have mobility of nurses and doctors and practitioners to actually practice where the needs were the highest. But then what you realize when you look at licensing is that it can be a huge barrier to actually shifting between provinces if the licensure applications don't look the same. So we have a case of Charlotte, who's a final year resident in psychiatry in Ontario. She had a depressive episode last year, leading her to take a 3-month medical leave from training. She sought treatment, she was able to make a gradual return to her clinical duties, and she performed well in her evaluations. By all counts, she's a great resident. She's now applying for her first independent practice license after finishing her residency. And so she applies first, she gets a job offer in Ottawa, the capital of Canada, and in Ontario, where she trained, and she applies to the Ontario Licensing Board. So these are questions she gets. So we're going to go through them. We're going to play the game, not the game. We're going to actually go through what she would actually be like answering on this application. So the first question is, do you currently have any medical condition that affects or could affect your ability to practice medicine? She says, no, I currently don't. I'm in remission. My depression has been treated. She says no. The second question is, have you ever had any medical condition that has affected or could affect your ability to practice medicine? And here she hesitates. She says, okay, well, I did have my depressive episode earlier in training. I mean, it was treated. I didn't make any wrong decisions. I knew when to slow down in my clinical work. I did take a leave, but it didn't affect my ability to practice medicine. And she really wrestles with it, as many people do in these disclosures, but she decides to say no. But then we have the third question. Have you ever taken a medical leave of absence of any duration from a medical school, a post-grad medical training program, or any professional position of employment? Please take note that all medical leaves of absence must be disclosed, even those less than 6 months in duration. So here, knowing that her training will reflect her leave of absence, she knows that she has to say yes. So all of a sudden, she's now disclosed. And what are the consequences of this disclosure? So I've just unleashed the fine print above the section on medical conditions for licensure in Ontario. So for every yes answer, provide a detailed explanation. You may be asked for additional information, i.e. a current report from your treating physician sent directly to the college, outlining your medical condition, setting out your diagnosis, course of treatment, present health, and prognosis. So once again, we have a lot of information that suddenly the college now would like to be able to review one's application for a medical license. So let's say that Charlotte also gets a job offer in Calgary, where her family lives. And she thinks, okay, I'm going to actually also apply to the Alberta Licensing Board to, explore that option. So the only question on their application for licensure that has to do with health is the following. Do you presently have a physical, cognitive, mental, and or emotional condition that negatively impacts or is likely to negatively impact your work? She confidently says no. She doesn't presently have anything that is impacting her work. So she finally, okay, we're going to do one more. She applies to work in Vancouver, where her family lives. Did we say that her family also lived in Calgary? Yes, they live everywhere. She has lots of family all over Canada. And she receives a job offer to work in Vancouver. And so she applies to the British Columbia Licensing Board. So this is the question that she's going to receive in the BC Licensing Board. do you have a physical, cognitive, or mental health condition that is negatively impacting your medical practice or is reasonably likely to negatively impact your medical practice in the future? This is a tongue twister. On top of it being, a disclosure practice for physicians, it is also to test their tongue twisting abilities. So for that question, she says no. But then they do ask once again, have you ever had or been advised by a healthcare professional that you have had a physical, cognitive, or mental health condition that, were it to recur, would be reasonably likely to negatively impact your medical practice? So again, we see repeats of questions. The reason I'm repeating these questions is because across provinces, you'll see sometimes the language is completely the same, sometimes it's slightly different. And with all of these, there's a calculus suddenly that each of these applicants is having to face to figure out, okay, is it safe to disclose? What might happen if I disclose? What kind of explanation do I have to kind of give to the college if I have a yes answer? And what does it mean for the information to be confidential? Here in the BC, the British Columbia disclaimer, it says such information is confidential to the college. But then, so as we see, it's highlighted here. But then you look at the end of the application. Oops, there we go. And so at the end of the application, you have to sign an authorization, which says, I further authorize any licensing authority or hospital, undergraduate or postgrad training program, or reference or individual to disclose to the College of Physicians and Surgeons of BC information otherwise confidential, and I waive any right of disclosure of same to me, and agree that communication between the college and the disclosure shall be privileged. So suddenly, this is a huge privacy moment. This is a very important moment for knowing where your information is going, who it could be shared with, what kind of information the college might request from third parties, and really know who is even at the college reading all of this stuff. So as we can see, it can be very daunting for anyone to say yes on any of these questions. And we're going to talk about what that actually means for policy. Is it actually solving the problems that it's hoping to solve? Or is it potentially creating problems that it might have been designed to solve? So we have another case, but I kind of want to actually get to some discussion. So I'm going to skip through this case, which is really about addictions. I'm going to skip through Quebec just because it's one of those provinces that looks at specifically questions about mental health. And it's one of those 5 provinces that actually asks about mental health specifically. So I want to focus your attention on the third question here, which is, do you have or have you ever had a chronic mental health problem, for example, schizophrenia or bipolar disease? That is a yes or no question with no nuance. Then the final question in this application is, do you have or have you ever had a problem of dependence or substance abuse, including alcoholism? I will say that physician health programs, which are very common among the US and Canada, essentially universal across Canadian jurisdictions, and I believe across US as well. These were bodies that were initially formed in conjunction with, but usually at arm's length from, licensing boards to provide support for physicians who had experienced some form of functional limitation. In their original inception, they were frequently there for physicians with addictions. So these were historically care sort of monitoring programs where physicians who had been flagged for arriving to work under the influence were then sort of funneled through this type of program. I think that there is great evidence for the use of physician health programs. I'm currently actually doing some work with the physician health program in my province. But what's really helpful to see is that these physician health programs have since expanded very, very much more beyond addictions and into disability in general, any form of functional impairment that is limiting a physician's ability to practice and providing support and referrals for those physicians. So it comes, interestingly, the support, it's not surprising, but some of my work is about regulation in physicians. What do we imagine physicians can be? What are the assumptions built into medicine from our socialization from day one of medical school into practice? Oftentimes, it's this idea that we are not patients, that physicians are not patients, that physicians don't have disabilities, that we are the selfless superhuman, as Dr. Jane's work has pointed out. And when in fact, many physicians exist and practice and thrive with disabilities. And this may inform their work. It may not. It may exist separately. And they're, part of the work is that a large number of people in this world have disabilities, and physicians are no exception to that. And so I think that my hope with the, I'm going off on a tangent now, but my hope is that with the regulation in future, as well as the use of physician health programs, my hope is that we're going to be able to understand disability along a spectrum of, the existence of disability, and then, to the whether or not it affects medical practice, into the realm where it does affect medical practice, where people need specific support and accommodations. So we're going to move on. That was my little tangent. I'm going to, okay, so I'm going to come back to this slide, which was our map of Canada. And as we saw, there's a lot of information contained in this one picture, in this one map. Not only is it, okay, what questions are asked where, but it limits movement for physicians with disabilities who may not feel comfortable disclosing. Moreover, when people do move between provinces, even if they're mid-career, it doesn't matter whether they're finishing residency or at the end of their training or at the end of their practice and they're moving provinces for whatever reason, these questions will pose barriers. And we know that, for example, physicians who might have been monitored for a substance use disorder in one province, once they've graduated from the program, they're no longer needing monitoring. But if they move to another province, they might actually, that monitoring process may start again. So suddenly, and monitoring would look like random urine tests and similar sort of monitoring practices to regulate the physician in that way. So again, moving provinces is not an easy thing. It requires a very complex negotiation of disclosure for the physician. All right, I'm going to talk about now kind of the policy analysis section of this, because I think there's a lot to unpack. As I imagine you all can imagine, and I'm also seeing in the Q&A that would be impermissible under medical privacy laws in the US and therefore actionable. Yes, I am not a legal expert, and I would be very, very curious to see if that's actionable in Canada. My understanding of Canadian law regarding the privacy piece of disclosure and which information, personal health information, is shareable or obtainable from applicants to the board. My understanding is that the law in Canada has to do with the protection of patients, and therefore it supersedes potentially. I'm not a legal expert, but my guess would be that that would be the way in which those regulations or policies were put in place. But I would have to check, and that's a really great question. I'm also seeing some things in the chat. Yes, okay. Okay, I'm gonna go at a slower pace to make sure that everyone can follow along. I apologize that I can sometimes get, when I'm nervous, I speak too quickly. We're gonna focus on the implicit questions about impairment. So one of the things is that in these applications, we had the explicit questions about impairment, about illness, about specific disabilities, but there were also actually implicit questions that were contained and embedded in these licensing applications. So, for example, as we saw in our first case of Charlotte, who had taken the 3-month leave of absence, 10 out of the 13 medical regulatory authorities in Canada actually asked questions about leaves of absence from training or practice, and often actually required substantial documentation to explain this. This could vary between any medical leave of absence, as we saw in Ontario, to any leave that was over 3 months in duration. So even if you have a condition that has involved, that has not involved any kind of functional impairment, if it involved any kind of medical leave of absence, that is something that they would need to disclose. In terms of the privacy piece, all of the medical regulatory authorities in Canada included a disclaimer about information privacy, informing applicants about their personal health, and how it would be shared with college staff and third parties at the college's discretion. So this was sort of a boilerplate privacy statement for all Canadian MRAs. And none of them were actually explicit in their policy, in the application questions themselves, about the repercussions of disclosure. So, what are the next steps? What happens after you disclose? I also want to talk about the framing. So this is getting into our critical policy analysis piece of where do these questions even show up in the licensing application? The licensing application, if anyone in the audience has ever filled out one of these, it's a long, at least the ones in Canada, they're pretty long. You have to go through a bunch of things about where you trained. Have you ever had any disciplinary actions? Have you ever had a criminal charge? Have you had any bloodborne diseases, which is a whole other thing? What have been your past training experiences? Where are your degrees from? Have you had any patient complaints or actions against you from your licensing body from that perspective, from a malpractice perspective? So interestingly, the questions about medical conditions were juxtaposed almost in all cases with questions about criminal charges and professional misconduct. Which, if you think about that, it implicitly starts to frame medical conditions as liabilities. So it's essentially the liability section of the application. These are sort of, framed in such a way that it's what are the potential risks of you as a provider to the public, which has severe consequences over people's actual willingness to disclose and how they also understand what is an appropriate way of being a physician with a disability, or a physician altogether. Physician health in these applications was framed as a fitness to practice and professional competence issue. Often even the section headings of these sections were fitness to practice or professional competence. And within those were the sub-questions about health. So it wasn't framed as, how can we support you? Or do you need to get in touch with the physician health program because we think you need help? It wasn't an issue of how can we support? It was really, are you fit to practice? And I can say, as a physician who's taken medical leave of absence and had to disclose in these questionnaires, it doesn't feel good. It doesn't feel good to sort of talk about one's own health and the ways that one took care of oneself to get the medical treatment that you needed, to suddenly have this be a fitness to practice category. And yeah, so so if anyone is going through this presentation and listening and kind of going through these questions and thinking, oh God, I've been here, or I don't, this is like a very daunting process, I'm right there with you. Okay, so when we apply critical policy analysis now, thinking of Carol Baki's approach, and actually I apologize if I never know how to pronounce her name. I've heard Baci, I've heard Baki. The spelling, based on my knowledge of Italian, would suggest it's Baki, but I may be wrong. So I want to provide that disclaimer. So thinking of critical policy analysis and Carol Baki's approach, there's a number of questions you ask when you look at a policy, but some of the key questions to ask are, what is the problem represented to be? What presuppositions underlie this representation? And what effects does this representation produce? This is very relevant to the work that we are all looking at now on policies around physician health, around licensing for physicians with disabilities. So the first one is, what is the problem represented to be? So like we said, like I alluded to, physicians with medical conditions in this case are framed as physicians with framed as liabilities, that they may pose a threat to patient safety and therefore might be unfit to practice medicine. Obviously, we know that this is not frequently the case, but this is how it's framed in the policy, the way it's currently structured. And what presuppositions actually underlie this representation? So the first one that a number of the current guidance documents allude to is this assumption that illness equals impairment, which we know is not true. The presence of a disability or of an illness does not equal impairment in the professional space of medicine, or in the decision-making, or in any of the specific aspects of the work of a physician. We know that impairment and non-impairment do not exist in a binary, but rather as a spectrum. But the presuppositions underlying this representation of disability, or of sort of fitness or unfitness to practice in these documents or in these policies is in fact the opposite. And then finally, there's a presupposition or assumption that workplace accommodations don't allow physicians with medical conditions to practice safely and competently. So really, I think a lot of the work in this space with docs with disabilities, with DREAM, with all of the research that's happening in this space, is highlighting just how much accommodations allow physicians with medical conditions, with disabilities, to meet the legal requirements of the ADA in the US, but also it allows these physicians to thrive and to practice in a way that benefits all teams, patients, et cetera. So, and what are the effects of this representation? So we see from research from Derby and from Gold from 2016 that this representation actually makes physicians less likely to disclose illness in licensing applications. They're more likely to forego treatment, accommodation, or leaves of absence. And it also limits the opportunity for early intervention, which could actually prevent illnesses from becoming impairing in the first place. So what effects does this produce? Again, so due to this is sort of thinking from a systems picture and from a larger level now, due to the underreporting of medical conditions, there's less motivation to invest in infrastructure and systems to support physicians who become unwell. So, if a program that supports physicians is saying, oh, well, there's not that many physicians with disabilities or with illnesses that require support, so why should we invest in this? That's what happens when we have underreporting of these conditions. And then if the problem is constructed to be about regulating individual physicians, we lose sight of the systems factors and workplace conditions that actually might be precipitating or perpetuating the impairments that we're seeing. So I want to do this graphically because it helps me a lot to understand what is happening here. What are the relationships that are here? So essentially in these policies, in these licensing applications, it's creating a binary. So if they're not meeting the current guidance, they're basically saying you either have no past or present medical condition, or you do have a past or present medical condition. And then the assumption is that if you have no past or present medical condition, fit to practice, no restrictions. If you do have a past or present condition, you may be unfit to practice, and that requires a review. It requires review of documentation and potentially monitoring. So how do you get from, having a past or present medical condition to being fit to practice with no restrictions? Well, it's a very opaque process that discourages disclosure, as we saw. All of the barriers to disclosure in these applications are going to be limiting that funneling between actually having a condition and being able to practice unrestricted. So now I just want to kind of show you what I did here. I moved the diagram up to show you some consequences of this relationship, of this opaque process. So what happens, as we mentioned, so when you're discouraging disclosure, physicians are then forgoing treatment, they're forgoing accommodations in the workplace, they're forgoing leaves of absence that might help them get through a flare-up, for example, of their disability. And then because of not seeking the treatment or the accommodations or the leaves that they would have otherwise had, that at that point may result in impairment at work. When we know that when we don't treat an illness, the illness may in fact progress. And so it's similar here. It's not the case for all disabilities, but for many of the chronic health conditions, mental health conditions, addictions, this may in fact be the case. So, and what happens when you actually do start to be impaired at work is at that point, the person may be unfit to practice and require monitoring. So physicians, ironically, the people who are regulating all of this, the people who are experiencing this as physicians with disabilities, they apply these interventions to the patients every day. This is part of recovery. This is part of return to functioning. And we know that the return to work is a very therapeutic piece, as long as it's done gradually and with the person's goals and needs in mind. So applying kind of what we know about medicine, what we know about treatment to physicians now, physicians who may have an impairment or who may have an illness that may be leading to impairment. So medical treatment, workplace accommodations, and leaves of absence actually can work. In the absence of those, we obviously have the barriers that we mentioned. But when we do actually implement these things for physicians, you actually get recovery and return to functioning and relapse prevention. And you have a physician who is fit to practice with no restrictions because, the condition that they have is not impairing at that point. So I want to go quickly through some of the work from the Meeks lab that looks a little bit at what it actually means to have access to the elements, whether that's accommodations, whether that's the treatment that someone requires to actually perform at their best as a physician. So in this study, which was published last year, they looked at residents with disabilities or first year like interns with disabilities, and they looked at whether their access needs were met or unmet. So this was this is from the intern health study. So this is like many, I forget the exact number, but it's over 1,000 residents who were surveyed. I'm sorry, I'm going to look up that number right after. But if their access needs were met, this meant that either they had a disability and wanted accommodations and got the accommodations, or they said that they didn't need accommodations and they were okay to function without the accommodations. If their accessibility needs were unmet, that meant that they had not requested accommodations, they had requested accommodations but had not gotten them, or I think there was another category. So if the access needs were met, they showed the same increase in depressive symptoms as non-disabled residents over their intern year, versus if they were unmet, they showed higher increase in depressive symptoms over the course of their intern year. Now, the very interesting part here, kind of related to impairment, because again, symptoms of illness may not equal impairment. When we look at impairment, so if their needs were met, their access needs were met, they had the same likelihood of medical errors as non-disabled residents. No difference. If their needs were unmet, however, they had a higher likelihood of medical errors. So when we think about these policies that are aiming to protect the public, to reduce the rates of errors, medical errors in practice, really what it's pointing to is not this sort of intense process of disclosure, but actually to the fact that we need accessibility to be we need accommodations to be accessible to physicians. So kind of coming back to this idea of what is the problem represented to be, just to kind of wrap up, physicians with medical conditions are represented to be liabilities in this problem space of the policies, and that they may pose threat to patient safety and may therefore be unfit to practice medicine. I want to couch this because the way that it's written in the slide makes it seem like this is a declarative statement, but really what I'm saying here is that how is the problem represented, not what the actual problem is. But a key factor affecting fitness practice is access to care, supports, and accommodations. So often the only way to access these involves disclosure, which many of the current policies implicitly discourage. So again, as I alluded to before, they might actually be creating problems that they had intended to initially solve. So just to review, why study physician licensure? I hope I've made that very, very clear, or at least kind of an interesting question for today. We went through background on physician licensing and best practice guidance, some cases and results of the study that we did in Canada, and some discussion of the critical policy analysis and implications for physician health disclosure and support seeking. So again, I'm going to come back to that final question. So, when someone asks you or one of your colleagues, will it affect my medical license to disclose in this licensing application? It's a complicated question. And the answer is that we often don't know. We don't know what the process is once someone actually does disclose in the application. I hear anecdotally extremely different reports all the time where people will disclose, they'll put in their documentation and nothing will happen. They get their license and there's no issue. And then sometimes people will get an entire review and there's no obvious reasons for the differences between them. And so I will put my thanks there to everyone on the slide and many others who have been involved in this space, in this research. And also thank you to Dream Research Rounds for having me. Oops, that's just extra info. But I'm going to stop there and I'll let Neera steer the ship again.
Wonderful. Thank you so much, Erene. That was a really interesting and personable walk through the complexity of licensing and the kinds of questions that trainees and physicians encounter. I'm going to open it up for questions in a minute. We don't have any